Welcome to the Deep Dive, where we extract the most important nuggets of knowledge and insight from a stack of sources, offering you a shortcut to being truly well-informed. Today, we're diving deep into a topic rapidly reshaping gynecological practice: robotic surgery in gynecology.
Indeed. And our sources this deep dive, they're drawn from recent academic publications. We're looking at comprehensive reviews on the evolution of robotic surgery, its applications in reproductive medicine and gynecologic oncology, and also some critical analyses of its impact, on surgeons, training, and even global implementation.
Right. So, our mission today is really to unpack the remarkable journey of robotic surgery in gynecology. We'll look at its maybe surprising origins, where it's being used widely now, and then get into the more nuanced discussions around its advantages, the challenges, and its evolving impact, on clinical practice, the surgeon's own experience, and even the environment. So, for you as an informed gynecological surgeon, this deep dive aims to provide a distilled, comprehensive overview. We'll highlight key data points and emerging trends, things that are really critical to understanding this transformative technology. Okay, so let's start by looking back. The origins of this robotic revolution are, well, maybe not what you'd expect. When we talk about automatons, the idea actually stretches way back. Think 400 BCE, Archytas sterentem mechanical bird. It's kind of wild to think that these ancient mechanical curiosities sort of laid the conceptual groundwork for today's surgical robots.
It truly is. And those early ideas, they paved the way for the actual term robot, which Carol Quebec introduced in his play back in 1921, Rossum's Universal Robots. And then Isaac Asimov defined robotic in 1942. This whole conceptual evolution was uh, absolutely essential before any practical surgical applications could even be thought about.
And those practical applications, they started taking shape in a really unexpected place. The military. The initial spark for surgical robotics came from a 1970s military project. It was approved by NASA, funded by DARPA, and the whole aim was to replace a surgeon's physical presence on the battlefield.
That's quite a leap, isn't it? From battlefield trauma to the precision needed in a GYN operating room.
It is. But that foundational military research, it quickly led to some significant milestones in medicine. The very first robotic surgery, that was in Canada in 1983. An orthopedic surgeon used a robot called Arthrobot. Then, shortly after, 1985, the PUMA 560 robotic arm assisted in a brain biopsy. These were, early steps, but they showed the immense potential for high-precision image-guided tasks. Yeah. And from there, things really picked up speed. We saw the first FDA-approved robot for abdominal surgery, ASOP, that's the automated endoscopy system for optimal positioning, in 1994. I mean, imagine holding and moving the laparoscope with voice control back in the mid-90s. Then 1998 brought both the ZEUS robotic surgical system with its 3D remote capabilities and, of course, the Da Vinci surgical system.
Right, and the ZUS system, despite its innovations, it was eventually discontinued after computer motion merged with intuitive surgical. That consolidation, strategically, allowed for this really focused and rapid development of what became the dominant force,
Yeah.
the Da Vinci system.
And the rise of Da Vinci is, well, it's a story of iteration, isn't it?
Yeah.
The early first-gen robots were more about image-guided precision, but it was really the second generation that brought in that crucial operator-executor setup where you, the surgeon, are directly controlling the robotic arms. Multiple degrees of freedom. That fundamentally changed the surgical landscape.
Absolutely.
Yeah.
And that second-gen Da Vinci quickly became iconic. The design, compact, mobile platform, 3 or 4 robotic arms,
Yeah.
and that immersive stereoscopic camera,
Yeah.
giving a tenfold magnified view. It completely revolutionized what a surgeon could see and do.
And Intuitive hasn't stopped there. Their third generation Da Vinci system, it pushes capabilities even further. We're talking forced feedback technology, better ergonomics, enhanced vision. They're also integrating things like operational efficiencies, looking at machine learning, and even artificial intelligence, AI. It's this continuous evolution, promising even greater precision down the line.
The global impact is just undeniable. Over 6,730 Da Vinci systems installed worldwide now, and they've performed more than 10 million robotic surgeries globally. For our fields, specifically, Da Vinci got approval for gynecological surgery in 2005. That was really the pivotal moment when this tech started integrating into our specialty.
Okay, let's shift focus now to the gynecological arena itself. This is where robotics really shines, but also where there's, ongoing debate. As a minimally invasive approach, it's now used for a whole spectrum of procedures, benign, malignant, even fertility-enhancing ones.
Yeah, if you compare it directly to traditional open procedures, the benefits are pretty clear, often significant. Patients generally have shorter hospital stays after surgery, less blood loss, and lower morbidity overall. These are really tangible improvements in recovery.
But the key question often is, How does it stack up against conventional laparoscopy? For surgeons, the advantages seem compelling, especially ergonomically. We hear about significantly less physical fatigue, less mental fatigue too, reduced stress during long, complex cases, and a huge reduction in musculoskeletal injuries. One study cited 94% reporting less physical tiring, 45% less mentally tiring, 48% less stressful compared to lap, and musculoskeletal injuries dropping from, 32% for lap down to just 0.7% with robotics. That's a profound difference for surgeon well being.
It really is. And beyond the ergonomics, the visualization is just a game changer. That 3D magnified view, sometimes with integrated fluorescence like the Firefly system, it gives unparalleled clarity. Then you've got the dexterity, the precision, those rifted instruments with 7 degrees of freedom, tremor-free handling. It allows for much finer suturing, finer dissection of delicate tissues. And crucially, the newer systems now have haptic feedback. That addresses a major historical complaint. Plus, you often get better access to difficult-to-reach spots.
And it seems like certain patient groups might benefit even more, right? Like obese patients or those with previous abdominal surgeries, maybe those needing really lengthy, high-risk procedures where traditional lap might be tough.
That's generally the thinking, yes. Those are scenarios where the enhanced visualization and dexterity of the robot can offer distinct advantages over conventional laparoscopy.
Okay, let's zero in on some specific applications where robotics seems to make a real difference. What about fertility preserving procedures, like myomectomy? It's the gold standard for symptomatic myomas, but it can be suture intensive. Does robotics help there?
Oh, absolutely. The robotic approach really excels in myomectomy. It eases that suture-intensive work, the knot tying, the complex closure of the myoma bed, things that can be quite challenging with conventional laparoscopy.
And what does the data show for outcomes?
Studies consistently find benefits like less blood loss, shorter hospital stays, fewer complications compared to open myomectomy. Operative times, well, they can be longer than open, but often comparable to laparoscopic myomectomy. And importantly, fertility outcomes and uterine rupture rates seem to be similar across robotic, laparoscopic, and open techniques, so it provides confidence in its efficacy for those goals.
What about endometriosis, especially complex cases? Deep infiltrating endometriosis. That magnified 3D view sounds ideal for adhesions and fine suturing.
It does. And for stages 3 and 4 endometriosis, the robotic approach is generally considered valuable, particularly for resecting deep infiltrating disease involving the bowel, bladder, or ureters. It's shown good outcomes there, similar operative times to conventional surgery in some reports. However, for less advanced stages, say stage 1 or 2, the benefits over traditional laparoscopy, they remain less certain. Some studies show no significant improvement in perioperative outcomes, so it really highlights the importance of careful patient selection. It's not necessarily the default for all endometriosis cases.
Makes sense. Precision is also key in things like fallopian tube reanastomosis. The delicate handling, the magnification, seems perfect for that kind of microsurgery.
Exactly. The first cases were reported back in 2008. Operative time might be longer than open, yes, but patients often have a shorter return to normal activities. And crucially, pregnancy rates are comparable. Studies also suggest similar costs per live birth compared to open approaches. So it's a really compelling, minimally invasive option for women seeking fertility after tubal ligation.
With C-section rates rising, we're definitely seeing more ismuscles, those cesarean scar defects. How does robotic repair perform?
It's shown good outcomes, significantly improving myometrial thickness post-repair. One study actually reported that out of 20 patients wanting children after robotic ismicel repair, 15 got pregnant and 14 had full-term live births.
Yeah.
That's quite promising.
Yeah.
And people are exploring combined techniques now, hysteroscopy, near-infrared vision, laser fiber, to get even clearer defect definition. So innovation is ongoing there too.
And what about those really challenging cesarean section scar pregnancies, CSEs, high risk of hemorrhage? Is robotic removal an option?
It can be considered, yes, particularly for cases where the ectopic gestation is growing out towards the bladder and the abdominal cavity.
Mhm.
The procedure involves careful bladder dissection, wedge resection of the gestation, and then a solid two-layer repair. The main advantage, complete removal of the products of conception right there during the surgery, which minimizes the risk of ongoing issues.
Okay. Abdominal circlage, another precision procedure, often needed when transvaginal isn't feasible. Do robotic techniques help overcome the limits of traditional lap here?
Yes, they often do. Robotics can address some of the challenges laparoscopy presents for abdominal circlage. One study found similar favorable obstetric outcomes compared to traditional laparotomy, And interestingly, no intra-op complications in the robotic group versus one in the laparotomy group. Though it's worth noting, in that particular study, estimated blood loss and length of stay were actually a bit greater in the robotic group, so nuances exist.
Moving beyond fertility restoration, robotics is also vital in fertility preservation, especially for cancer patients, right? Like robotic radical trachelectomy for early cervical cancer.
Exactly. For early-stage cervical cancer, the robotic approach to radical trachelectomy shows comparable pregnancy and birth rates to laparoscopy. It's a feasible option for preserving the uterus in selected patients.
And other preservation techniques.
Well, ovarian transposition can be done robotically before radiation to help prevent premature ovarian insufficiency. And we're even seeing descriptions of robotic assistance for orthotopic ovarian tissue transplantation, using things like human extracellular matrix scaffolds. The idea is the improved visualization and dexterity might minimize graft time out of body and potentially enhance tissue survival. Really cutting-edge stuff.
Let's pivot now to malignant gynecology. Starting with endometrial cancer, robotic hysterectomy, BSO. That seems pretty standard now for early stage cases.
It is, and often considered the most effective treatment. It offers marked benefits, especially in obese patients where minimal access might otherwise be very challenging.
But cervical cancer, there's more debate there, isn't there, following the LACC trial?
Yes, absolutely. While minimally invasive surgery, including robotic, gained popularity, that LACC trial in 2018 raised serious concerns. It found worse survival outcomes for minimally invasive radical hysterectomy, including robotic, specifically for tumors larger than 2 centimeters. This has led directly to ongoing randomized trials, RACC and ROCC, which are specifically assessing the outcomes of robotic radical hysterectomy to give us clearer answers. It's a really important area of current research.
Okay. And for ovarian cancer, where does robotics fit?
Primarily in staging for early-stage cases, and also in selected cases of interval debulking surgeries. Another key area is the sentinel lymph node technique. Robotic platforms, with their enhanced visualization, are great for identifying SLNs in endometrial and cervical cancer, though it's important for surgeons to know that not all current robotic platforms can detect the ICG tracer commonly used for SLN mapping. That's a practical consideration.
This brings us back to that crucial point about ongoing debates. While MIS, lap, or robotic is clearly better than open surgery in many ways, the definitive superiority of robotic over conventional laparoscopy for all GYN conditions, that hasn't really been universally established, has it? Especially by prospective trials.
That's exactly right. A good example is the LaRose trial for endometriosis. It was a randomized controlled trial. It found no significant differences in operative length, perioperative parameters, or quality of life between robotic and conventional laparoscopic surgery. It just highlights that while robotics offers clear advantages in specific situations, complex dissections, fine suturing, maybe ergonomics, it's not necessarily a blanket upgrade over a standard laparoscopy across the board. It's more nuanced.
Right. Let's shift focus again, this time to the human element. The impact on you, the surgeons, and on training. We touched on ergonomics, but it's worth hammering home. That huge reduction in physical and mental fatigue, stress. The numbers again. 94% less physically tiring, 45% less mentally tiring, 48% less stressful. That's significant. And the drop in musculoskeletal injuries from 32% in lap down to 0.7% in robotics. For career longevity, that's huge.
The physical benefits are definitely clear, but there are cognitive challenges too, especially early on. One survey found about 32% of respondents felt robotics negatively impacted their intraoperative situational awareness. The main reasons cited were being physically at the console, away from the team, reduced overall visual perception of the room, and maybe impaired communication. And this is critical, this feeling improved significantly as surgeons gain more robotic experience.
And what about that historical lack of haptic feedback? The sense of touch?
That was definitely a big one. About 26% of surgeons reported it negatively impacting their surgical ability historically. But again, this perception tends to improve with experience. And importantly, newer systems are actively incorporating force feedback technology. So that's becoming less of an issue over time.
Interesting. Some studies even looked at potential gender differences in the learning curve or risk aversion. What did they find there?
Well, there were some intriguing observations. Men were apparently 6 times more likely than women to report a negative impact on situational awareness early on, and 2.5 times more likely to say the lack of haptic feedback negatively impacted them. Also, women tended to be a bit more risk-averse in case selection, particularly early in their learning curve, while men were perhaps more likely to tackle complex cases sooner.
So fundamental differences in capability.
Not necessarily capability. The key finding was that these reported differences seemed to resolve as the number of cases performed increased for everyone. And importantly, there were no self-reported differences in actual intraoperative complication rates between genders. Experience seems to be the great equalizer here.
Okay, let's talk training. How fast can an experienced surgeon typically pick up robotic techniques?
Well, the learning curve is often reported as faster for surgeons already skilled in open or laparoscopic surgery because they're learning a new technology, a new interface, rather than the entire surgical procedure from scratch. And things like dual console training, where a trainee and proctor can operate together, seem to significantly speed up that learning process.
But there seems to be a concern about standardization, right? A study found many robotically trained surgeons didn't follow a structured curriculum, relying more on informal proctoring.
Yes, that's a significant point. It really highlights an urgent need for standardized, competency-based training programs, ideally led by surgical colleges. This means developing clear, operative performance indicators, OPIs. Basically, measurable benchmarks to define what competent robotic surgical performance actually looks like. Standardization is key for consistent quality.
Okay, let's widen the lens now. Beyond the OR table, let's look at logistics, economics, the global picture. A major drawback, always discussed, is cost. High installation costs, maintenance, disposable instruments.
Absolutely. That's a primary hurdle. And the data on cost effectiveness compared to conventional laparoscopy. It's often inconsistent. It's complex. Yes, the initial acquisition and per case instrument costs are higher for robotics, but
Yeah.
some analyses suggest the potential benefits like shorter inpatient stays and maybe reduced complication rates could lead to lower overall hospitalization costs in certain specific settings or for certain procedures. It's just highly variable. It depends on the procedure, the technique, surgeon experience, and very importantly, the specific healthcare economic system you're in. No easy answer.
And how do different groups measure the success of a robotic program? Does management see it differently than clinicians?
Often, yes. Hospital management might focus on things like annual procedure volume, how much the robot is actually being used, utilization rates, and the number of surgeons trained on the system.
Whereas clinicians.
Clinicians are typically more focused on patient outcomes, postoperative morbidity, length of stay, complication rates. Though what's encouraging is that one survey found 74% of respondents felt introducing robotics increased the overall proportion of surgeries done via minimal access routes in their center. So it seems to be helping expand MIS access overall, which is a positive clinical outcome in itself.
This technology also starkly highlights global disparities, doesn't it? The research seems heavily skewed towards high-income countries.
Dramatically so. One statistic showed 94.2% of robotic surgery research in GYN oncology comes from high-income countries. Virtually zero representation from low-income countries. And even for middle-income countries, their published research tends to get significantly lower citation rates and appears in lower-impact journals compared to high-income countries. The challenges for low and middle-income countries, LMICs, are huge. The high costs, often a lack of pre-existing MIS skills among surgeons, insurance coverage issues. It really calls for more collaboration, more support between high-income and lower-income settings to try and bridge these gaps.
Finally, let's touch on something often overlooked but increasingly important: the environmental footprint. Healthcare has a significant environmental impact, and robotic surgery contributes to that.
It does, and the data is quite stark. Some analyses suggest robotic procedures can result in around 44% higher greenhouse gas emissions and 24% higher waste production compared to standard laparoscopy.
That's substantial. Is there much awareness of this among surgeons?
Apparently not enough. One study found only 3 out of 30 surgeons interviewed were even aware of the specific environmental impact of robotic surgery. It suggests a real need for education within the surgical community on this topic.
Which leads directly to the idea of green theaters, right? What kinds of things can be done?
Exactly. Initiatives like using reusable equipment where safe and feasible, improving repackaging to reduce waste, optimizing surgeon preference cards so you only open what's needed, and things like avoiding high-impact anesthetic gases like desflurane. These are all critical steps. It's about finding ways to balance the incredible clinical benefits of robotics with our environmental responsibilities.
Okay, looking ahead now, the future horizon. Robotic surgery isn't standing still, is it? We're seeing new platforms emerging.
Definitely not. There's a clear progression from the traditional multi-port systems towards single-port systems. Think Da Vinci SP, MIRA, Novo. The goal there is to minimize incisions even further while trying to maintain maneuverability inside the body, pushing MIS boundaries.
And beyond single port.
We're seeing emerging flexible robotic devices too. These are designed for endoluminal approaches, going through natural orifices, and transluminal approaches. This could really expand surgical targets beyond where traditional laparoscopy can easily reach, opening up totally new intervention possibilities.
And this all seems to be converging towards this idea of a digital surgery ecosystem, doesn't it? The OR as a kind of data-driven control center.
That's the vision, yes. Integrating multiple streams of real-time data analysis. And AI artificial intelligence is poised to play a truly revolutionary role in this, enhancing precision, hopefully improving outcomes, and potentially expanding what surgeons are capable of doing.
How specifically might AI be used?
Oh, in many ways. Analyzing vast amounts of data points from past surgeries to refine techniques, learning from algorithms, collecting data simultaneously during a procedure imaging, patient history, live vitals to allow for on-the-go adjustments, and enhanced decision support.
And visualization. Things like AR and VR.
Exactly. Augmented reality, overlaying critical structures onto the surgeon's view, virtual reality for training. Maybe even AI suggesting alternative approaches or warning about nearby critical structures. Also, creating incredibly realistic surgical simulations for risk-free training. And perhaps eventually automating some of the more repetitive surgical tasks to improve efficiency. And this connects to the potential of telesurgery, too.
Right, the idea of skilled surgeons operating remotely.
Exactly.
Yeah.
Manipulating robotic systems from distant locations. This could theoretically democratize access to high-quality surgical care globally. Of course, this absolutely requires robust, high-speed data transfer, reliable network infrastructure, comprehensive telemedicine systems. It's technologically demanding. But systems like Japan's Hinatori are already developing guidelines for remote-assisted robotic surgery, so it's moving from science fiction towards reality.
It's an exciting future, but as we wrap up, it's crucial to reiterate that need for more research, isn't it?
Absolutely critical. We still need larger, well-designed observational studies and particularly more rigorous randomized controlled trials. These are essential to definitively establish long-term outcomes, especially cancer outcomes, and true cost-effectiveness across different procedures and settings. The potential is huge, but it must be guided by robust evidence.
What an incredible journey we've taken. Through the evolution, the current applications, and the future potential of robotic surgery in gynecology, it's so clear that while the tech offers these immense advantages, precision, ergonomics, patient recovery compared to open surgery, its comparison with conventional laparoscopy is, well, it's much more nuanced, isn't it? Ongoing research keeps refining that picture.
Precisely. We've seen how it can reduce surgeon fatigue, enhance capabilities in really complex cases, but it also brings up these important questions. Training standardization, global equity, that environmental footprint we discussed, the integration of AI, single-port systems, telesurgery. These promise a future where surgical precision and accessibility could reach entirely new heights. It's truly reshaping our field.
So, as you, our listener, reflect on this deep dive into robotic surgery and gynecology, maybe consider this. How might the increasing integration of AI and that growing emphasis on green theaters, how might that reshape not just your own surgical practice, but maybe the very ethical framework we use for adopting advanced surgical tech in the coming decade? What stands out to you as the most critical area for immediate attention right now in your own practice or your institution when it comes to robotic surgery?